My name's Andrew Dunn. I'm a musculoskeletal radiologist based up in Manchester in the UK at the 𝐏𝐻𝐝 Centre. I also work for the Fortius clinic in London. For the next 25 minutes, I'm going to talk about imaging muscle injury, particularly looking at the grading systems and some of their potential limitations. So I'm going to start by considering why we bother grading muscle injury. And like any other grading system for any other injury, grading provides an indication of injury severity. And with regard to muscle injury, this allows us to predict restoration of function, which we define as return to playtime. It can potentially identify surgical candidates, which is very important. And in that situation, it aids surgical planning. And in some instances, it may predict the probability of re-injury. This is a slightly contentious issue, and there's quite a bit of literature on this subject. What makes a good injury classification system? And I think the questions you have to ask yourself is that it has to be simple to apply and simple to understand. It, particularly with muscle injury, this is not just radiologists and sports medicine physicians that need to understand grading systems. Football coaches also need to have an awareness of grading systems, and if they become too complex, then they just will end up being underused. We also need to consider the pathoanatomical factors within the grading system, which has to encompass the full spectrum of injury. And that's very important, and I'll discuss that in a bit more detail later. Also, they want to be reproducible grading systems with good inter-observer agreement. And ideally, we need to have them clinically validated. So when reporting muscle injury, one of the key things that I always sort of tell my trainees and colleagues is that anatomical definitions are key. And those are essentially having consistent definitions in your reports, and so that you and your referrers know exactly what you're describing. With the majority of muscle injury, a muscle fiber interface with connective tissue is usually involved, what we would call a myoconnective tissue junction. Now, when we're talking about muscle fiber injury, one of the definitions taken from actually one of the original grading systems is that of between minor and moderate partial tearing. So minor partial tearing of muscle fibers would be defined as a disruption of a primary muscle fascicle, and that may produce muscle fiber separation, which produces interfascicular hemorrhage, which we see on imaging. And these are usually defined as tears less than 2 millimeters in transverse dimension. Moderate partial tears are defined as macroscopic tear defects, usually disruption of a secondary muscle fascicle, and these tend to be greater than 2 millimeters in transverse dimension. Just to show you a schematic, and this is actually taken from the consensus paper from the Munich grading system, and this just schematic illustrates nicely the different definitions of the primary and secondary muscle fascicles. So here we see a minor partial tear involving a primary bundle, whereas a moderate partial tear involving a group of muscle fascicles forming a secondary bundle. And on imaging here, we see a small, less than 2 millimeter transverse tear defect with a moderate partial tear defect of greater than 2 millimeters. Just to show you an illustration, this is taken from Carlos Pedret's recent article describing sonographic assessment of muscle injury. And this is the definition of the muscle connective tissue junction. So if we look at muscle fibers, then all of them will eventually have an interface with some form of connective tissue. That may be tendon, which as it thins out becomes aponeurosis, or it may be going to the muscle periphery, where we may see epimysial surface interface or perimysium interface. And when we're describing muscle injury, it's important to include the structure at which the injured muscle fiber is interfacing with. Another important definition is that between tendon and aponeurosis. Many tendons will eventually form an aponeurotic structure, which is defined as a sheet-like fibrous membrane. Some tendons never actually form really true thick tendon bundles, and throughout the majority of their length are aponeurotic in their nature. And a good example of that would be in the lower leg, where the tendons of soleus are typically flat and aponeurotic. So it's important to have a definition of aponeurosis or tendon, or an interchangeable descriptor, which I think is useful, such as the aponeurotic tendon, because if the word tendon is not used, this can lead to confusion in report interpretation. An example here just showing this is the distal extent of the conjoint tendon, where it forms a flat aponeurotic surface on the biceps femoris, and we can see a tear of that structure. Here we see the distal biceps femoris tendon would be what's described as the T-junction, where we have a confluence of flat aponeurotic tendons between the long head and the short head. Another type of tendon structure may be seen where there's a combination of tendon and aponeurotic components. And this is the semimembranosus. The proximal intramuscular portion has a thick tendinous portion and a thinner aponeurotic portion. And obviously injury may occur within either of those two components, hence the name semimembranosus. Part of the tendon is membranous and flat. Another important observation is that of anatomical variation, and there's a high degree of anatomical variation in the hamstring muscle tendon units, particularly in the conjoint tendon. The intramuscular portion within biceps femoris may have a curvilinear shape. It may be thick and cord-like. It may have two distinct limbs in an L shape, or it may even have three limbs, such as this triradiate intramuscular tendon. And tendon injury may occur within one or multiple of these tendon limbs. The significance of that is that a small tear within a small portion of the tendon may not necessarily result in the same functional or structural impairment as that seen in a tear involving multiple limbs of the tendon. And in addition, you may actually see two distinct limbs of the conjoint tendon. This is a biceps femoris. This isn't an old longitudinal split tear. This is just simply anatomical variation of the conjoint tendon forming two distinct bundles. So it's important to be aware of that so that you're not overcalling acute longitudinal split injury. So moving on to grading systems, I'll start with the sort of oldest and most established grading system. That is the Pitron grading system, which was originally described using ultrasound and then modified for MRI. Grade 1 injury is defined as acute muscle fiber separation, but no transverse myofibril disruption. And this produces that interfascicular edema, giving that feathery appearance we see on MRI, which is hemorrhage only between muscle fibers. Grade 2 is a structural muscle tear or tendon fiber injury with transverse fiber disruption. Again, that can occur within muscle or tendon. And so this is one of the limitations of this grading system, which didn't differentiate between connective tissue or muscle fiber injury. And grade 3 is a complete transverse disruption of the muscle or tendon unit. Moving on to the Munich grading system, and this is a consensus grading system put together in, I think, 2010, which tried to group injuries based on functional types, giving them types 1 and 2 with subtypes A and B. And it was the first grading system to apply anatomical locations, importantly splitting these into injuries of the muscle tendon junction, or injury at the interface of the tendon or myosseous junction. And again, grading these as types 3 and 4 with subtypes A and B. And you can see in the schematic there the typical location of these different types of injury. Obviously, the higher number and the higher grade being anatomically and functionally more significant locations for injury. This grading system did undergo some validation study. There's been a couple of these. The most widely quoted is that of Jan Ekstrand, which looked at a large number of hamstring and quadriceps injuries. You can see that the majority of these were the slightly higher grade structural types. So we weren't considering the neuromuscular and myofascial type injuries. The majority of these were structural muscle tears. Interestingly, though, only 60% reported the size of the tear. There was a discrepancy between clinical and radiological grading of functional injury, as you might expect, because a lot of functional injuries don't always have imaging abnormalities. Return to play was longer for structural injury and higher grade quadriceps injuries, and subgrouping of structural injury had positive prognostic relevance. The Barcelona Aspetar system came a few years later, and that was the theory behind this grading system. I thought was very good. This was based upon mechanism, location, grade, and recurrence. The mechanism split into direct and indirect, location based on proximal, middle, and distal location within the muscle tendon unit, and then a description of whether it involved the muscle tendon junction, whether it involved myofascial, which included aponeurotic and epimysial surfaces. The grade was based upon the cross-sectional area of high signal intensity in the muscle. And again, it had another sub-grading system looking at the re-injury rate, whether it was a first recurrence or second recurrence. So in theory, this had a lot of good points. It was anatomical. It also had implications for mechanism. But when you actually put it into practice, it becomes a little bit unwieldy. So if we look at an example here, we can see a longitudinal split injury of the proximal conjoint tendon within biceps femoris. So we have an indirect injury. It's involving the tendon. It's proximal. It's involving greater than 50% of the muscle cross-sectional area. And it's the first injury, so it's an R0. So if you actually describe this injury, it's an ITP4 R0 injury. Now, that does not exactly trip off the tongue. It's not particularly easy to explain that to an athlete or explain it indeed to a football coach. And I think it had, although this had good research potential, this was just practically wasn't a very easy grading system to use. Which brings me on to the British Athletics grading system, which was originally described by Noel Pollock and some his other colleagues too, a radiologist, Steve James and Jay Lee, and Robin Chakravorty, and this was introduced in 2016. And again, this had anatomical information, which is the key differentiator from the Petron system. And this described injuries in the proximal, central, and distal third of the muscle tendon unit. Grade 0 injuries were grade 0A was a normal MRI scan. Grade 0B was the features we see with sort of exertional or delayed onset muscle soreness with faint, well-defined areas of edema, usually surrounding an intramuscular tendon, such as this in rectus femoris. This was completely asymptomatic. And we also see some semitendinosus edema outlining the intramuscular raphe. Grade 1 injuries, again, the type A's were peripherally located. They were small in cross-sectional area, less than 10%, and less than 5 centimeters in length. Grade 1B injuries involved the muscle tendon junction. Again, less than 10% of the area of the muscle and less than 5 centimeters in length. The grade 2 injuries were macroscopically slightly larger than grade 1. So the grade 2As, again, were peripherally located, involving up to 50% of the muscle area with 5 to 15 centimeters of length. And the 2Bs, which are probably a lot of studies validating this being the most common type of muscle injury, involving the myotendinous junction or central location within the muscle. Again, less than 50% of the muscle cross-sectional area with between 5 and 15 centimeters in length. And the grade 2C injuries, the C-type injuries were functionally and anatomically more significant. These involve the intramuscular tendon. So the grade 2Cs, we see a high signal intensity within the tendon. This can be transverse fiber disruption or a longitudinal split, extending for less than 5 centimeters in length or less than 50% of the cross-sectional area of the tendon. Loss of tension in the tendon may be present. The grade 3 injuries were larger still, so a greater than 50% area, greater than 50% in length, but peripherally located for a grade 3A. The 3Bs, same criteria, but involving muscle tendon junction. And the 3C, which is a high-grade intratendinous injury, may involve greater than 50% of the transverse tendon area, or greater than 5% in length. And these often have associated loss of tension in the longitudinal plane, which is a key feature and shown to have adverse prognostic outcomes. An example there showing a 3C injury of the conjoint tendon with loss of tension in that intramuscular tendon. Grade 4C is a complete tear of the muscle or tendon. Surgery is usually indicated for these injuries if they occur proximally. Here we can see an extensive injury. This was a grade 4C injury, not only of the conjoint tendon, but also of the semimembranosus. And we can see distal retraction and laxity of both those structures. A grade 4C injury, which is distally located, is functionally less significant, and this in this instance was treated conservatively. So here we see complete disruption of the distal end of the conjoint tendon within the long head of biceps femoris. There's a good surrounding cuff of intact muscle fibers, although they do demonstrate interfascicular hemorrhage, and these now quite frequently are treated with PRP injection. One type of tendon injury which you may encounter, which is functionally and certainly with a return to play implications are less significant, is that of the tendon split. Just to show you an example of this, here we see an injury of the conjoint tendon showing a 40 millimeter longitudinal split. On the British Athletics grading system, we would say this is a proximal third grade 2C injury. Now, these can sometimes return to play in a surprisingly quick fashion. This is this return to play in just 12 days. As I say, return to training 1 week later. You can notice that there's no loss of tension in that. And contrast it with this injury. Here we see a grade 3C tear of the conjoint tendon. We see high-grade transverse fiber disruption. We see loss of tension in the tendon. There's also a longitudinal split extending distally. So that's a 3C injury. Even with PRP injection, this took 8 weeks to return to full training. Contrast it with this injury. This is a longitudinal split. So you can see the tendon splices into these composite bundles. There isn't much loss of longitudinal plane tension of the tendon. This, because of its length, grades as a 3C injury. But this return to play, again, had a PRP injection in just under half the time that the previous 3C injury took to return to play. So the longitudinal split functionally and on prognostically is a less concerning injury. Tendon tension, as I mentioned, also implies higher grade injury. It's mentioned in the British Athletics paper and others. The presence or absence of tendon tension could resolve the split versus transverse tendon tear debate, in that with transverse fiber disruption, you're much more likely to see loss of longitudinal plane tension. And that can help when you're describing tendon injury. It can be useful to use that descriptor to help prognosticate on potential return to play. One type of tendon injury which is not included in the British athletics system is that of the tendon strain. And what we see in this situation on imaging is simply peritendinous edema. So here we can see an injury of the proximal extramuscular portion of the semimembranosus tendon. We can see edema encircling the tendon, but there's no signal abnormality centrally within the tendon. So this does not fit the criteria of the 𝐏𝐵𝐸𝐼𝐶 classification system. And these can be relatively quick to return to play. This injury took 2 weeks to resolve. And again, depending on the length of the segment of tendon, this can sometimes longer tendon strains can sometimes take longer to settle down than shorter ones. The other significance of the 𝐏𝐵𝐸𝐼𝐶 system is less important for more distal tears. So as a muscle extends distally, it usually tapers down and reduces its cross-sectional area. So the significance of the cross-sectional area becomes less important. So here we can see a relatively small injury involving the distal biceps femoris myotendinous junction with interfascicular hemorrhage, but you can see proportionally, this is involving quite a large amount of the muscle belly, which increases its grading up to, in this instance, this would be graded as a 3B injury. Although you can see that the degree of muscle fiber disruption is relatively low grade. And that just took 14 days to return to play. Similarly, as you go further distally in the muscle, the cross-sectional area of the tendon tapers and reduces. And so the estimation of the involvement of that tendon in the setting of a tear becomes less accurate. So again, anecdotally, there's more recurrence of tears along the distal end of the proximal intramuscular tendon, and that possibly reflects inaccuracy of initial evaluation of the magnitude of tendon fiber disruption. So just to show you an example here, we've got the proximal conjoint tendon. If I was to say to you, try and estimate 50% of that tendon, it would be much easier to describe that than trying to estimate 50% fiber disruption of this portion of the conjoint tendon, which is further distal. I'll show you this example, which is an injury which was initially reported elsewhere, I hasten to add, as a 2C injury. But if you look more closely, you can see that there's complete absence of tendon fibers. And we can see on the longitudinal coronal image that there's retraction of the tear margin and laxity. And this is actually a complete tendon disruption of the distal conjoint tendon. And this was actually a grade 4C injury. Again, this did not require surgery, but was treated with PRP injection. But still, this would be potentially an 8-week injury versus if it was a 2C injury, we'd be talking more along the lines of 3 weeks return to play. Another area which has been described as a increased risk for recurrence is the distal biceps femoris T junction. So injuries that involve or approximate the junction between the short and the long head intramuscular tendons have a reported higher risk of local recurrence. And these are not necessarily high-grade injuries. They may be just relatively small myotendinous junction muscle fiber injuries, such as this case here, where we see recurrent grade 1B injuries occurring over the course of 3 months. Moving on to injury in the lower leg, as I've already mentioned that the lower leg, particularly soleus, has a complex and highly variable connective tissue anatomy. We see multiple intramuscular tendons in the soleus. These usually arise from the fibula and extend into the medial soleus as well as the lateral soleus. And the distal connective tissue typically forms a posterior aponeurosis with a central intramuscular septal tendon. Injuries of the intramuscular septum again have a reported higher return to playtime. As a result of that complex and variable connective tissue, the tear morphology can be quite complex and variable as well. We may see L-shaped tears. These are particularly seen involving the posterior aponeurosis of soleus and the anterior aponeurosis of gastrocnemius, where we have a short horizontal component of the tear and a vertical or longitudinal split, which may extend proximal or distal from the area of transverse tearing. We may also see L-shaped tear morphology in the biceps femoris, typically in the distal aponeurotic tendons, and we may also see it in the rectus femoris, usually in the posterior aponeurosis. And this type of connective tissue injury can also be seen in flat ligaments, such as the medial collateral ligament of the knee. We may also see more complex U-shaped tears, typically in the gastrocnemius aponeurosis. So just to show you an example, here we see a longitudinal split of the gastrocnemius aponeurosis, which extends distally into a short area of transverse tearing. So this is that L-shaped tear morphology that I was describing. It is the transverse portion of the tear which is functionally the most significant, because this allows potential retraction of the connective tissue and muscle fibers and produces loss of tension. Here we see a U-shaped tear, so we see two vertical longitudinal splits which converge distally into a segment of transverse disruption. Again, you can see here there is potential for retraction of the aponeurosis and the muscle fibers. So again, functionally a higher grade type of injury. Grading system for the lower leg, again, has more recently been described using the Prakash grading system. And this is what I've been using this for a couple of years now. This was by the Melbourne group, including Dave Connell and Peter Bruckner, which, when you look at the craniocaudal dimensions and definitions in the BAMIC classification system, they can't really be accurately applied to the lower leg. I mean, the BAMIC system was described for hamstring injury. And so this is a grading system which considers the anatomy of the calf musculature in a bit more detail. So grade 0 injury is essentially edema with no myofibril disruption. So we see these faint, hazy areas of edema within the calf musculature. Grade 1 injury is described as myofibril detachment, but without any connective tissue disruption. So the tendons and the aponeuroses are intact. So we see interfascicular hemorrhage, but no laxity or high signal within the aponeuroses or tendons. Grade 2 injury is where we see myofibril detachment, and we see a longitudinal split or delamination of intramuscular tendons. So here we see a typical type 2 injury involving the lateral soleus intramuscular aponeurotic tendon. And grade 3 injury are where we see myofibril detachment with transverse disruption of the connective tissue. And this results in loss of tension. You can see that here in the medial gastrocnemius aponeurosis. And we see proximal retraction of the muscle belly. So again, a much functionally and anatomically a much higher grade of injury. The Prakash grading system has had a validation analysis, again seeing a progressive increase in return to playtime, particularly with those transverse fiber disruptions, the grade 3 injuries, showing a wide range of return to play times as high as 70 days. So in conclusion, the British Athletics Muscle Injury Classification System, I think, is the best hamstring classification injury we have, although it does have limitations, particularly with regard to the longitudinal split versus transverse fiber disruption. Having anatomical definitions is key when you're reporting and describing muscle injury, as well as predicting return to play. And the knowledge of intermuscular and anatomical variance and the location of the injury within the connective tissue is key to its successful application. The 𝐏𝐴𝐸 classification system provides guidance, but also sport-specific knowledge is useful. And recurrence risk factors warrant discussion, such as injuries involving the distal T-junction of the biceps femoris. And again, the significance of the tendon split versus transverse tear is a subject of debate. I certainly find that when I see a longitudinal split injury, if I'm asked what I expect the return to play time is, it is a lower return to play duration than an injury that has transverse fiber disruption. And again, the appreciation of whether there is loss of longitudinal plane tension of the tendon is a useful prognostic factor. Thank you for your attention.